Hello. Okay, so today we are on surgery. We're going to chest injuries. We're going to do chest injuries. Okay. I'm hopeful that you guys are able to view the slides from your hand. Okay. Well, I'm good. So chest injuries. This time when you talk about what we call the injuries of the brain and then central nervous system at all. Okay. Neurotrauma. So the neurotrauma, and that is today we're going to check on the chest injuries. MBCHB 50-year content. Now, for this, you're supposed to be, or you're expected to be able to classify and identify chest injuries, discuss the role of the chest radiograph in chest injuries, indication for thoracotomy, yeah, getting inside the thorax, the thorax cavity, and then getting outside, or maybe opening through the thorax to correct, diagnose, yeah, do an operation, thoracotomy, okay? Understand the principal indications for and management of chest tubes. Also be able to list the complication of chest injuries, okay? So in Kenya, talk about chest injuries. Kenya, no inclusive statistic about it, but we can just talk about developed world, which is commonest injuries in young adults, actually, that is the chest injury. It accounts for around 25% of all the trauma death that we have in casualties comes mostly from the motor vehicle collision from motor vehicle, just road traffic accident. So in Kenya, Kenyatta National Hospital, there were 3 month period where there was total of 319 trauma admissions, 10.7% were thoracic, but then 5.9 of the thoracic cases, the cases required surgery. And when talk about the male to female ratio, it was 6 to 1. That is to mean male was 6 times more uh, exposed or predisposed to thorax or chest injuries, unlike female. Nigeria, the same statistic, 6 to 1, that is in terms of male to female ratio. Then Liberia was 4 to 1, okay? That is actually during 1971 to 1976 statistics. Now, talk about chest trauma. Chest trauma, first you get it from mechanical injury, can be either high velocity or low velocity. Just from a few meters tree and you fall down, low velocity. High velocity maybe high collision motor vehicle, maybe you're on a motorcycle and then you had an accident with another rapidly moving motor vehicle. Talk about thermal injury, it also can cause chest trauma. Chemical injury can also cause chest trauma. So this chest injury can even happen when women pour hot water on husband and son after they have a row. So that is that. Maybe you overcrowded the vehicle and the vehicle is moving so fast. Or you just slide in the river. It can also happen when you have revolt stress blows after two leads up. Then like when two people fighting can get to have it. So let's check on how we can classify the trauma. We have penetrating chest trauma, we have non-penetrating, we have inhalation injury, aspiration of foreign bodies. So penetrating, non-penetrating. So non-penetrating is what we call blunt injuries or crash injuries. So there are actually two major forces within chest which lead to injury, either compression force or distraction force. So the compression results in distraction of vascular components, causing hemorrhage, that is bleeding, edema, because if you have hemorrhage, then there'll be swelling, and impairment of function. So the distraction injuries usually result in shearing forces which destroys the integrity of intrathoracic. So we talk about penetrating injury as one of the first classification. This is just the 61% of the chest admission. It can be results in parenchymal damage related to tract of muscles or maybe stabbing implement and velocity care. So the muscle structures like heart, these solid structures like heart and major vessels, they suffer greater injury where high velocity missiles are penetrating weapon. So most lethal complication is hemorrhage, that is bleeding, okay? And that one we all know. And often associated with abdominal trauma. Talk about blunt injuries, still under penetrating injury. This is just non-penetrating, Acceleration, deceleration injuries, the blunt injuries. So the sudden reduction in speed, but the road traffic accident common cause of death and is also one of the causes of blunt injuries. So you can have aortic rupture as a cause of death and on site, not uncommon of course. So care in dealing with the very young and the elderly is considered. Talk about crash injuries, one of the non-penetrating chest trauma. Crash injuries now occur when elastic limits of chest and its contents have been exceeded. So the patient usually have arterioposterior deformity, okay, and majority have flail chest with multiple fractures or pneumothorax or hemothorax. You need to know the call it flail chest. This is when we have multiple rib breakage. Yeah, so in such a case where we have multiple breaking ribs, you realize the movement of chest is the portion of the rib cage that is floating and does not move with the respiration, so it moves separately. Call it flail chest, okay? Most have pulmonary contusion, just abrasion on the lungs, pneumothorax, the hair on inside the thoracic cavity, hemothorax, blood inside the thoracic cavity, okay? That is in the lungs, okay? So crushing injuries of heart, the aorta, diaphragm, liver, kidney, spleen, these are very common. Another group of patients with crush injuries are those with what we call the traumatic asphyxia syndrome. Traumatic asphyxia syndrome is where now constrictive forces are applied over a wide area for as little as 2 to 5 minutes, okay? And therefore will have asphyxia. So severe crushing injuries have a high mortality rate, and you can appreciate from the image there mechanism of respiration, and when I talk about each organ you can also see them. So let's check on the symptoms on sign. First, you need to have an history of trauma to the chest, pain at the site, especially when breathing in, and guarding of the injury. We also talk about hemoptysis, possible cyanosis, either pale or cold skin, rapid pulse because of yeah, hypoperfusion, okay? And then also rapid shallow breathing because of distress, respiratory distress. So typical severe chest injury. In severe chest injury, talk about neck, face blown up with air, bubbles of air escape into the tissues, or in air in the pleural cavities, get them, open chest wound. It's a bit different, eh? Yeah. So that is that. Physiological effect. Hypoxia comes in, that is just reduced oxygen exchange. Acidosis because of anaerobic respiration, then low cardiac output because of hypovolemia and a cardiogenic shock. So when we talk about casualty management, we normally have primary survey, secondary survey. Then you have investigation, transfer to ward or theater, and never forget associated other injuries, okay? So don't just go direct and manage chest injury, forgetting that this was traumatic accident, therefore there are possibility of other injuries. You have airway, breathing, circulation, dysfunction, CNS, and exposure. Those are the primary surveys. So primarily we have the A, B, C, D, E, okay? Airway, you have to clear the airway of all debris. Chin lift and the jaw thrust or tongue and confirm using airway, endotracheal tube, cervical care throughout, okay? Check for life-threatening condition like airway obstruction, that only if we're checking breathing, tension pneumothorax, cardiac tamponade, massive hemothorax, and flail chest. In the oxygen circulation, you need to check, we need to restore circulation if it was almost collapsing. Check of systolic pressure progressively falling, urine down to 50 ml per hour or less, collides or ringus lactate. We check those one. Types of chest injuries needing urgent attention like tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, and cardiac tamponade. So tension pneumothorax, just potential killer condition, and no radiograph needed. Okay. So a clinical diagnosis, of course. So chest drain insertion needed immediately in tension pneumothorax, and it uses other tube in absence of the chest drain tube. Okay. Yeah. So talk about open pneumothorax, like you only apply occlusive dressing as surrounding tissue may act as a flutter valve. So then definitive closure to follow, and then chest drain is also supposed to be added. Types of pneumothorax. We talk about closed, open, tension. Okay, those are pneumothorax, and you should know actually how they appear in the X-ray. Okay. Let's talk about massive hemothorax. These are great blood loss than 1.5 liters and chest drain insertion, fluid replacement. Then need to avoid too high in BP and also rule out vascular injury in and if surgery needed, need to prepare someone for surgical operation. So let's talk about flail chest, okay? Yeah. So before flail chest, you'll be actually checking on pain relief in such a situation. And take care to avoid precipitating lung injuries and acute respiratory distress syndrome. Monitor blood gases and also intubate if goes into respiratory failure. Okay. The cardiac tamponade, just elevated CVP, muffled heart sound, and hypotension. And pericardiocentesis is also very key in such a case. So warning is that should impale object leave in situ till the patient is in the theater. Bandage and the stabilize object to reduce the damage. Okay. Indication for immediate surgery. So like cardiac tamponade with its indication, electromyocardial dissociation with it, and then intra-abdominal bleeding in excess. That's also another indicator. So when talk about secondary survey, we are done with primary survey. Talk about second examination, chest X-ray, which actually single most important assessment, and then blood gases, ECG if needed be another relevant investigation. Study that. So that is actually very important. Hope you are at home. Yeah, yeah. So, when we're managing such patients, we first restore normal anatomy and physiology of the bleeding, early re-expansion of lungs, full restoration of pulmonary function, and then prevention of complications like control organ failure. Then we talk about prevent infection and control the blood loss. So, importance of monitoring, that one is very key, but we'll check it on the next day. Have a nice time and good night, everyone.